So today's topic is important, commonly encountered in intensive care, hypertensive crisis. Hypertensive crisis. So we know hypertension is a silent epidemic in today's world. Nowadays, hypertension is common in young age. Geriatrics are also already a common population which are affected with hypertension. Prevalence is 29 to 30%, 34% more than 20 years of age. So the emergencies are classified like acute severe hypertension, hypertensive emergency, hypertensive urgency. What is acute severe hypertension? It is sudden onset, rapid, very high blood pressure. Hypertensive emergency, whenever acute severe hypertension associated with target organ damage, that is called as hypertensive emergency, and it needs immediate treatment. Hypertensive urgency is acute severe hypertension without target organ damage. So in acute hypertensive emergency, blood pressure is usually more than 200 by 120 millimeters of mercury. With retinopathy, acute renal failure, thrombotic microangiopathy, or hypertensive heart failure, also called as malignant hypertension. So there are a number of risk factors including geriatric age, obesity, previous coronary artery disease, etc. And it needs immediate treatment. So acute target organ damage. What is acute target organ damage? So different organs are involved, taking from head to toe. The hypertensive encephalopathy can be there. PRES syndrome, that is posterior reversible encephalopathy syndrome, common in eclampsia, preeclampsia, severe sepsis, carcinoma, stroke, seizures, vision loss, intracranial bleed or subarachnoid hemorrhage, etc. In hypertensive retinopathy, we know already there is a classification called as Keith and Wegener classification. In hypertensive retinopathy, there can be flame-shaped hemorrhages, cotton wool spots, papilloedema, thrombotic microangiopathy, acute kidney injury. Then in cardiovascular system, target organ damage is there can be accelerated hypertension, acute coronary syndrome, left ventricular failure, aortic dissection. In sympathetic crisis, may be caused by pheochromocytoma or cheese reaction. So in case of hypertensive urgency, long-term damage is there. There is no acute damage. So what is the etiology of hypertensive emergency or target organ damage? The hypertensive emergencies could be because of essential hypertension, endocrine causes like pheochromocytoma, Cushing syndrome, primary hyperaldosteronism, or renin secreting tumors, Takayasu's arthritis, correction of aorta, burns, post-operative hypertension. In case of CNS, there can be cerebral edema, hemorrhage, spinal cord trauma, or GBS. In GBS, there can be autonomic instability and raised blood pressure. Drug causing hypertensive emergency include cocaine, amphetamines, sympathomimetics, or antihypertensive withdrawal, that is chloride withdrawal, tyramine or cheese reaction with monoaminic oxidase inhibitors, serotonin syndrome with selective serotonin reuptake inhibitors. Okay, so management principles of hypertensive emergencies include we should not decrease blood pressure by more than 25 to 20 to 25% within first hour. So we should admit patient to ICU. IV antihypertension, oral antihypertension can be used. IV hypertension most commonly used are labetalol, NTG, sodium nitroprusside, nicardipine, clebidipine, and hydralazine. So what are the threshold recommendation? In first hour, we should not decrease blood pressure by 20 to 25%. In 2 to 6 hours, we must decrease blood pressure systolic to 160 and diastolic to 100 by 120 millimeters of mercury. In last 40 to 72 hours, we can normalize the blood. So there are specific clinical situations or scenarios with hypertension and their treatment I have mentioned here. So clinical specific scenarios include hypertensive encephalopathy or PRES syndrome, that is posterior reversible leukoencephalopathy syndrome. The most commonly drugs used are labetalol. It is preferred over sodium nitroprusside. It has less effect on cerebral blood flow and maintains intracranial pressure. Alternative drugs are nicardipine, phenaldopam, clebidipine. We must avoid ACE inhibitors. In acute ischemic stroke, labetalol is a drug of choice. Calcium channel blockers like nifedipine can be used. and but NTG and SNP worsen the cerebral perfusion, so must be avoided. In acute hemorrhagic stroke, the blood pressure should be systolic blood pressure should be maintained to 140 by 140 to 150 meters of mercury in first hour. If patient is non-hypertensive, if we are reducing blood pressure less than 140, it can be dangerous. So it may cause itself stroke. If intracranial hemorrhage is large, so blood pressure can be maintained to 180 millimeters of mercury. In aortic dissection, it is a life-threatening situation. So systolic blood pressure should be reduced to 120 or less than 120 millimeters of mercury, and heart rate should be reduced less than 60 minutes of mercury within first 20 minutes. So most commonly drug used are the short-acting beta blocker like esmolol, long-acting beta blocker like labetalol, metoprolol, then nicardipine, SNP and SNP, that is sodium nitroprusside and nitroglycerin. We know in PIH the blood pressure is itself more than 160 by 110 millimeters of mercury. In severe PIH, there are chances of end organ damage. So drug most commonly used are methyl-dopa, then labetalol, nicardipine. If patient land up in eclampsia, we use magnesium sulfate. Sodium nitroprusside can also be used, but it causes fetal cyanide toxicity, and adrenaline also causes fetal tachycardia. So better to avoid those drugs. Acute coronary syndrome with hypertension, the blood pressure should be reduced. Systolic blood pressure should be reduced less than 140 minutes of mercury within first hour, and diastolic blood pressure should be more than 60. Most commonly used drugs are nitroglycerin. We use nitroglycerin for infusions, labetalol, AC inhibitors, or angiotensin receptor blockers. Acute pulmonary edema with hypertensive crisis, it is a hypertensive heart failure. So a drug of choice is SNP, but commonly used in nitroglycerin or NTG, and loop diuretics like Lasix. Better to avoid beta blockers in hypertensive heart failure. In renal emergencies, most commonly drug used labetalol, sodium nitroprusside, and ultimately, if not controlled, then we do dialysis, hemodialysis. Avoid AC inhibitors or angiotensin receptor blockers because in bilateral renal artery stenosis and hyperkalemia patients. Post-operative hypertension most commonly can be because of pain, so better to manage pain. The short-acting beta blocker like esmolol can be used. If not controlled, then labetalol, nicardipine, etc. In adrenergic crisis because of cocaine or amphetamines, we must sedate the patient by Lopez or some benzodiazepine. Then phentermine can be used. Chlorine, if we are using, it has got sedative effect, so it is additional effect for chlorine. In pheochromocytoma, we know that it is episodic hypertension. We use NTG or sodium nitroprusside. First of all, we do alpha blockade, and then we use beta blockers. Okay, thank you.